Endometriosis.
Hi. How are you?
Fine, and you?
Good, thanks. Good. Thanks for joining.
Well, good afternoon, ladies and gentlemen, and a warm welcome to all our delegates over here. We've got over 200 people logged in, and that's no doubt a tribute to our speaker, Dr. Abri de Bruin, who is an international and nationally known personality. We're going to hear in a second about his talk and his presentation and the sponsors. But firstly, I'd like to thank Steve and the Pelvic Floor Foundation of South Africa for setting this up, and for the use of his office, and of course, traditionally the use of his minibar. So Steve, thanks very much. He's not with us at the moment in the office. As you can see, he's actually at home. And Steve, thank you for being with us. I'm going to introduce Dr. Abri de Bruin now. He's a man from the University of Pretoria. He's widely known in those circles in Pretoria and Gauteng, and indeed in the whole country. And more importantly, he's widely known internationally, especially in Europe, where he sits on the board of the ISGE. Abri also is locally connected with the local organizations dealing with endoscopy, and he is a trainer locally and internationally. He's a man of immense talent, and when he's not, when he finds time, when he's not actually working, he also does a bit of cycling. And what else do you do, Abri, in addition to cycling?
Photography.
In fact, photography. He was recently over here in Cape Town on Sunday, and he came in after me at the Cape Town cycle race. I saw him, and he was a couple of minutes behind me. So Abri, thanks for finishing, and and I'd like to secondly thank our sponsor, who used to be known as Cooper Africa, and who's now known as Lorimer D. And thanks, a great big thank you then. Lorinda Sinclair is there, as you can see. She's going to be saying a few words to Abri and on behalf of Cooper Africa, and as it's now known as Lorimer D. Abri's presentation this afternoon is Diagnosing Endometriosis and Polysystic Ovarian Syndrome by means of Sonar examinations. So it's a topic that's near and dear to all of us. It's an important topic because it's such a common thing, endometriosis and polycystic ovarian syndrome. He runs a unit at the Mediclinic in Pretoria. It's a specialist referring unit, and he's done over 2,000 cases of grade 4 endometriosis. So he's a man that is ideally placed to be speaking to us this afternoon. And thanks again to Lorinda and Lorimer D. Next week, just to remind you, a heads up, we've got Professor Phil Steer, who's another good friend of ours, and he's going to be speaking on the Royal College of Obstetrics and Gynecology and the Royal College of Midwife ABC initiative to improve intrapartum care. So that too is something to look forward to next Thursday. Pencil that in. So without any further waste of time in Abri, thank you very much indeed for being with us this afternoon. It's a great pleasure and especially a great privilege to have you this afternoon and be with us for this talk, Diagnosing Endometriosis and Polycystic Ovarian Disease or Syndrome by means of Sonar examination. Well over 200 people have logged on so far, Abri, attesting to the popularity of you as a speaker. Thank you very much indeed, Abri.
Yes, and from my side as well, Pete, I'd like to welcome Abri. He's a good friend of ours here in Cape Town. Spent a lot of time training and teaching, so and also without a doubt a world expert on endometriosis. And also judging from the camera, I saw him bring to Kenya to the ISGE meeting with the lens, which was basically about 1 foot long or 2 feet long, massive camera lens. So, you know, judged on his camera lens, I think he's a very good photographer as well. So Abri, looking forward to seeing maybe some of your pictures in your presentation as well. But welcome, Abri, and you can start sharing your slides.
Is it sharing?
We can see something. Maybe you can
The
just
role
stop
of
the show.
ultrasound in gynae practice. That's what we can see.
Okay, good. Thank you very much, Pete and Steve, for the very kind words. Yeah, I completed my 15th August on Sunday. So it was great it was the first time in 42 years that the August was not on the second Sunday of March since its inception. So it was, but the weather in Cape Town, I always say that Cape Town's got 10 good days of weather in a year. Sunday was one of them. So I thought of talking just a little bit more than just PCOS and endometriosis, because I found that there were more important things to add on as well. So hopefully that helps a bit. So I'm going to look at general settings on your ultrasound machine: uterus, fibroids, adenomyosis, Mirana's, ovarian cysts, and endometriosis. So for basics, which way should your image be? Should it be upside down or should it not be upside down? What is your focus plane? What is your size of your image? And what should we do with Doppler and blood flow in early gestation? So basics, firstly, this is the image that we're going to see. We're going to see the half circle at the top if you are doing your ultrasound with the image to the bottom, and some people like doing it the other way around. And so the image orientation, if you scan with a half circle at the top, then right on the image will be right on the patient. And
Aubrey, can I just ask?
Yo.
You're talking about vaginal probe scanning in this case, are you?
Yeah, I'm not. Look, in my opinion, abdominal ultrasound is limited to obstetric. So all my images are going to be transvaginal, except the ultrasounds that I'm going to show you about the kidneys. They are transabdominal.
Well, thank you.
So these are transvaginal ultrasound. So if your image is this way around, then right on the screen is right of the patient and left on the screen is left of the patient. And the guideline is to always scan in the same way. So you start at the uterus, you do your length, width, transverse diameter, endometrium, then ovaries, where they are, their size, follicles, the cysts, and then other things. So we tend to get carried away if you put in the ultrasound, you find something what's weird looking, and then you suddenly just start looking at that. So stay in your normal routine on how you're doing your ultrasound, and always do it in the same manner, because then you're going to get more used to what is normal and what is not normal, and you're going to then spend time later on what you find that is abnormal. So firstly, what is the size of the image? So when we look at the image on the screen, we need to look at our bounding box. We need to look at zoom. When do we go up and down? When do we turn knobs? What's the focus area? And the gain. So I tried to compile this video just to show you. This is on my ultrasound machine, so it's not on everyone. The three most used buttons are the one with the bounding box. So the bounding box is this button. And what that essentially does is it creates a box on your screen, and which you can enlarge and make smaller. And if you click on that button again, you'll see that then you're just scanning in that box. So enlarging the image or shrinking it is that same button, but we're just going up or down. So you'll see on the ultrasound machine, we are going, and that we'll shrink it when we have a large uterus, or we will increase it when we want to have a look at an ovarian mass or whatever we want to look at. You can see then it grows, it gets bigger. And then the focus position is this little arrow that I'll show you now. So this arrow you want to have in the area so that you can move it up or down, but you want to have that in the area where you're actually doing your ultrasound. And then gain is merely whether it is brighter or less bright. And we use that a lot in 3D. So in early pregnancy, what on your ultrasound machine, you have TCB, you have TCS, you have MI, and what on earth does that mean to a gynecologist, which are not engineers? TCB is your thermal index of bone. TCS is your thermal index of soft tissue. And what is MI is your mechanical index. And the guidelines from the Sonar people is that those values should be less than 1. And we should also use the time that we're using the blood flow on the baby and the heartbeat to a minimal in the early pregnancy. So for me, that see patients post-IVF, and I see them when their babies are 1 centimeter long, that is when everyone wants to see the heartbeat and everyone wants to see the color of the heart and hear the heartbeat, but we don't want to keep that on too long. So what I usually do is I tell the husband or the wife to give me the phone, and I will then record that for them so that I can do a short recording where everything is in focus and not shaking. So just remember that if you have a very early pregnancy, not to keep the blood flow and the Doppler going on for a long time. So that's the same. You can see there the TLB, the mechanical index, TBS. So these are the values that we're looking at, and we would like them to be less than 1. So do a short run of the heartbeat. You can measure the heartbeat, and then you get the value, and that's more than what they want. I mean, in any case, they're not going to share a half an hour video of a heartbeat. They're going to share a short video clip on their status or whatever on WhatsApp or Facebook.
Aubrey, can I
So
just ask a question? Our fetal assessment folk down in Cape Town say that we shouldn't listen to the heart. Now you're saying color Doppler. What about listening to the heart? When can you put a color when can you put an audible track on that heart? Is it safe to do it before, say, 10 or 12 weeks?
This is the audible one. So I'll recommend that. Well, now I'm listening to what the fetal specialists here say. So I asked them, and they said if you use it for a 10-15 second interval, that's not going to make any difference. But you don't want this to be a prolonged sonar.
That's irrespective of the gestational age.
Well, no, I'm just talking confirmation pregnancy. Okay. So once they get once the baby is longer than 1 centimeter, I want to know nothing about that baby. So then they get referred to the fetal maternal specialist. So they will be able to answer you better on how long in later gestations. But these are confirmation of pregnancies. So this baby is 1 centimeter or 9 millimeters or whatever. So this is a small early confirmation of pregnancy following IVF. So I will just do a 10-second run on this heartbeat.
Okay, thank you.
Then we said in the order that we're going to do the ultrasound, we're going to do uterus, cervix, ovaries, bowel, and bladder. So just to help you orientate with regards to orientation of the uterus. So if the uterus is facing this way, then we are now sitting with an anteverted uterus. This is a patient with the anteverted and anteflexed uterus. So there's the cervix is coming from the top. This is a patient with an anteverted and a retroflexed uterus. And then this is a retroverted uterus. And most of the patients say, yes, the doctor said my uterus is inverted or backwards. It's fine. It's a normal occurrence. It does not, you don't have to do anything about a uterus being retroverted. The only thing that you must know is that if you're going to do a 3D on these uteruses, then your image is the other way around than when you have an anteverted uterus. So that's a retroverted, retroflexed uterus. And we typically see that in deep endometriosis, where the endometriosis literally pulls this uterus to the in the pouch of Douglas.
Aubrey,
so
just before, Aubrey, you just mentioned a 3D scan. Why would you want to do a 3D scan on a uterus?
Because that's the gold standard of evaluating the uterine cavity. You'll see in the slides coming what we're looking for. So standard diagnosis, the gold standard at the moment of evaluating a uterine cavity is 3D ultrasound. It's replaced an HSG, it's replaced most of the things. So we are now only actually interested in what the cavity looks like on 3D ultrasound. That'll also guide me on whether we need to do a hysteroscopy or not. So a 3D ultrasound of the uterine cavity is actually one of the most important parts of your ultrasound that you must do.
And Abri, sorry, that is used with the, it's a special 3D vaginal probe that you're using there.
Yeah, so I've got a 3D vaginal probe, yes.
Okay.
Yeah. You'll see now. So this endometrium is a proliferative endometrium. So this is pre-ovulation. So what we have here is we can clearly see that there are, so let me just see if I can get a mouse here. Sorry, just want to get my mouse. So there are 3 white lines, and the white lines are separated by the black areas, and that is the mucus in the glands, and that's why this is pre-ovulatory. Now I just need to figure out why this is. Okay, so there we have a mouse. All right, so this is now where we have a 3D, normal 3D image of the uterine cavity, and you can see where the 2 tubal ostia are coming out of the endometrial lines. And this is a patient with a T-shaped uterus. So you can very clearly see the T shape in this uterus. So this uterus has, when you do a hysteroscopy, the idea is that you need to see both ostia at the same time. So when you enter through the endocervical canal. So if you now go and you do a 3D ultrasound that looks like this, you can then see that if you're going to do a hysteroscopy, you're not going to be able to see the ostia. And the reason why you're not going to be able to see the ostia is because there is the T shape of this uterus. And this is what we don't want because it has a negative impact on fertility. So we will have to repair that. This is a patient with a secretory endometrium. So she's post-ovulation. There's another normal triangular shape in a secretory endometrium. And then this is a cavity where you can clearly see that there is pathology. So you have these cystic areas in the uterus. And this is a patient with Asherman syndrome that had adhesions, and those were fluid collections in between the adhesions. And yesterday at the update, Suleiman Aylan gave a very nice talk about Asherman syndrome and the effect on fertility. So this is a patient with an adenomyoma in the just below the endometrial cavity. So that is endometriosis inside the uterus that's actually formed a cystic mass. And this patient had 5 failed fertility procedures. We resected that adenomyoma, and she conceived spontaneously the month following the surgery. And then one thing, patients never want to hear that they are constipated and that their pain is caused by constipation, but it's something that we can actually see very nicely on ultrasound. And here you can see the bowel that is full of stools. So this area in the bowel is constipation, and that is one of the reasons why these patients have pain. And there you can see constipation again. Then something that's become very, very common at the moment.
Abri, can we just go back to the constipation?
Yeah.
How would you differentiate that from, I mean, we all see normal colon contents. How do you know it's normal, or how do you know it's constipated contents, if I may ask?
So the one thing that we do is, if you do a vaginal examination, which many gynecologists are now stopping to do because they do only transvaginal ultrasounds, you actually have to do a vaginal examination. You can literally feel the stools through the posterior vaginal wall. And if I see this picture on ultrasound, I will then send this patient for an abdominal X-ray. An abdominal X-ray will then give you an idea on whether this is just normal content that's in the rectum area, or whether this is a full colon. So I make my decision on whether I think this is normal or abnormal based on clinical examination combined with the ultrasound, and then do an X-ray if that's necessary or not. Does it make sense?
Thank you. Thank you very much.
So cesarean section niche or cesarean section scar defect is this. So what we have here is we have this large defect in the anterior wall of the uterus where the cesarean section was done with fluid that gets trapped inside the cavity. And what it does is, number one, it causes these patients to have a chronic vaginal discharge. And number two, it causes infertility because the embryo drowns inside this uterine cavity. So this is not due to the surgeons doing something wrong. It has, because I've seen this in patients who's been with gynecologists that have been practicing for 30 years, and I'm seeing this in patients with gynecologists that are newly qualified. So whether the suture material has changed, whether there's anything else that has changed, but it's something that we're seeing more and more often, and it's something that one needs to look at because it is very relevant. And there are two ways of fixing this, and we can either fix this hysteroscopically or laparoscopically. But a very, very important diagnosis to make. Then congenital uterine anomalies. If you do a coronal transvaginal ultrasound, you turn your probe, you will see that we now have two uterine cavities that you can see. And if you do a 3D reconstruction, then you're going to see what is happening here. You can see that there are clearly two cavities, and this is a didelphys uterus. This patient had a complete double system. This patient came to see me because of infertility, and she had a baby. You can see the cesarean section defect in the middle, and then you can see the V at the top. So she has a septum, and with that septum, she carried a baby to 36 weeks of gestation. Now we know, well, tomorrow ISWAG starts, and last year already it was consensus that septums does not need to be removed. You do not need to operate the septum. It has no positive impact on outcome of a pregnancy, and it has no negative impact on outcome of pregnancy either. So this is a good example of a patient that had a cesarean section, and she had this septum in her uterus, and she had a baby. There's another one, and the most important thing to see on these images is we always look, and I can't get my mouse to work now, but we always look at the top of the uterus to differentiate between a bicornuate and a septate uterus. So if the top of the uterus is round, like you can see in this image, this is a septate uterus and not a bicornuate uterus. Then something else that causes pain in patients that we see very often is pelvic congestion syndrome. So essentially varices in the pelvis, and you get this massive amount of blood vessels and varices around the cervix. And we see this with laparoscopy as well. You get massively dilated venous system in the pelvis. And this is one way to also narrow down your differential diagnosis in a patient that presents with pain. Because not everything is endometriosis, and not everything is constipation, and not everything is psychological. There are things that we can do to pick it up. So with color Doppler, we can very nicely see if you have these increased vasculature in the paracervical area. And the thing that you can do to help yourself is to put your color Doppler when you see a patient that you see for routine examination, and get used to what the blood flow is in a patient with no pathology. And then if you carry on doing that, you're going to very quickly be able to see when you have a patient with an abnormal blood flow in the lower pelvis area that can be due to pelvic congestion syndrome.
Aubrey, can I just ask you about this pelvic congestion syndrome? Because we've in our hospital we've got a vascular surgeon who's very interested in this stuff, and they're now taking patients for stents and all sorts of things. Are you currently involved in that sort of treatment as well? I mean, and what is your opinion on it?
Well, at the moment, the problem is you actually need a very good interventional radiologist to be able to deal with this. And the thing is, we don't really have good interventional radiologists. So we can refer them to interventional radiologists. And I think that is important. Or the only other therapy that really makes a difference is that we can put them on progesterone-only tablets.
Abri?
Peter, do you want to say something, Pete?
Yeah, I was going to ask the same question, but there's another question come up by Anicia Ziki. Abri, if you look at that particular image that you have on the screen, he says, Anicia, could that not be adenomyosis because of the cystic areas? How would you differentiate that from adenomyosis?
This currently in the picture on the screen now.
Yes.
It's not. This is cervix. This is not.
Okay, so
you can't see
cervix.
This is paracervical. This is not inside the uterus. The uterine cavity is separate to this. It's not on the image. So the cervix comes from the top of the screen, and this is actually the uterine artery that you see with the vein crossing over the artery, and you can actually see the ureter as well. The ureter is on the left-hand side. I just wish I had a mouse to show you. Let's see if I use a stamp. No, it doesn't want to allow me to do that. Oh, maybe if I can do it. No, I can't do that. So the ureter is actually that area there. That is the ureter.
Where?
So that is where the last mark was that I made.
Okay.
The rest, I'm blind on where I make them. So and then you can see the uterine, that's the uterine vein and the uterine artery there. So this is next to the cervix. This is not adenomyosis inside the uterus because the uterine body is not visible on this ultrasound.
Okay, thank you very much. He says thank you. And the final question on the ISMO seal from Oscar Shamangi. There's a belief that an ISMO, I don't quite understand Oscar's question, but you probably would. There's a belief that an ISMO seal might be doing an incision too low on the uterus, that in most instances is the upper part of the cervix where there's essentially no muscle tissue, thus poor healing.
Yeah, that's very possible because if I look at cesarean section scars, they seem to be getting lower and lower and lower. I'm just worried that they're going to make the incisions in the near future in the upper legs. That's how low it's going these days.
Yeah, no, Aubrey, it's a common mistake to make your uterine incision too low. And the lower you go, closer to the, shall we say, the cervix, it's a big mistake. You should stick in the lower segment and avoid the cervix at all costs, because it just makes it exceptionally difficult Caesar. Thank you.
Yes, for sure. And if you then get a placenta previa or a placenta accreta, then you're in deep trouble.
Yeah, I agree.
There's also another question here from Druzila and Yanlunga. The cystic area is not picking up color. Can it be Nabothean cysts as well?
That's a good question.
No, because that's not the cervix. The cervix is, I'm just going to quickly escape here or stop sharing if I can. I don't know how. I want to find my mouse so that I can show you where the cervix is. No, text is not going to work. Let's try draw. So the cervix essentially is there.
Okay.
So that's the cervix there. So the Nabothean cysts is not there. This is the ureter. The bottom part where these arrows are, that's the ureter. Because I know where to look for the ureter because we do it for the endometriosis.
Okay, thank you, Abri.
All right, so let's go on to the next one. Fibroids. Oh, now I'm going to have all these things on the screen the whole time. So let me try and see if I can undo them. Yes, I can. Okay, so just to show you that this is a patient that was booked for a myomectomy, but before she arrived for a myomectomy, she fell pregnant. And on the left side of the screen, you can see the uterus, the fibroid, and the baby is fine next to the fibroid. So the fibroid does not always preclude a pregnancy from happening, and it doesn't impact on the pregnancy the whole time. So let's go back. So the fibroid on the left is not impacting on that pregnancy. That pregnancy is ongoing, and that pregnancy is that patient actually delivered a healthy baby. So not all fibroids impact fertility. So fibroids are essentially, we need to decide in the FIGO classification. FIGO 0, 1, 2, and 3 are the fibroids that actually play a role in fertility. FIGO 4, we're not sure. 5, 6, and 7 are completely irrelevant to fertility. So here you can see the fibroids that are actually right next to the endometrial cavity, and those are the ones that have an impact on fertility. There is another fibroid. That's the fibroid that is a FIGO 4. So that is intramural, close to the endometrial cavity, but it does not affect the endometrial cavity. So that is a question, do we take out that fibroid, yes or no? That is a debate. So my primary answer would not be to go and remove that fibroid. And because you're going to make a defect in the uterus, and you need to make sure that you suture it properly. So for that fibroid, I would not take out that fibroid if the patient presents with infertility, and that fibroid is not going to cause bleeding. There's a patient with a retroverted uterus and a fibroid that's in the cavity. So that will cause abnormal bleeding and also infertility. And this is just a patient with a massive multifibroid uterus. You can't even see where the endometrial line is. You just have these large fibroids, and there's no point in trying to go and remove these fibroids via laparoscopy. These fibroids are for open surgery and to make sure that you get out all the fibroids as well as you can and make sure that the cavity is actually fine. There's another fibroid right slap bang in the middle of the cavity. So that one is removed hysteroscopically. And here you can see a posterior fibroid that is pushing on the endometrium. And that fibroid, anterior fibroid that's pushing on the endometrium. So sometimes this will cause pain, and sometimes this will actually cause increased bleeding. And this also can play a role in fertility. The problem with this fibroid is if you're going to take out this fibroid, you'll need to make sure that you suture the uterus very well. And the reason why I say that is that the biggest risk for a rupture after a myomectomy is a hematoma that forms in the skull. So if you're going to take out that fibroid, you need to make sure that you're going to close this uterus in at least 3 layers to prevent a hematoma, because it's the hematoma that's going to make a defect in the uterus. And when that patient then goes in and deliver, she runs a risk similar to a classic cesarean section of a rupture of that uterine wall. So if you want to take out such a deep fibroid, make sure that you can suture properly. There's another patient, intracavitary fibroid. This patient I saw earlier this week. She's now been on 7 different contraceptive tablets. And the initial diagnosis for her pain and her bleeding was an appendicitis. I just made no comment with regards to that, but none of the pills are going to work for a fibroid that's sitting inside the cavity. So that fibroid needs to be removed by hysteroscopy. And just some small, very important 2 tips. One, you will need to use a bipolar resectoscope in saline. I don't think that monopolar surgery inside a uterus has any place. And secondly, everyone is worried about fluid loss and TERP syndrome and all of that. Actually, you only need to look at one thing, because it's impossible to measure how much fluid you're losing, because there's fluid on the sheets, there's fluid on the linen saver, there's fluid on the floor, there's fluid under your shoes. So you're not accurate with how much fluid you're losing. So what you need to know is what the patient's CO2 is doing. So the only thing you tell the anesthetist is, A, during this surgery, you don't leave for a cup of coffee, and B, you only look at the CO2 level. Because if the patient's CO2 level drops, that means there's a decrease in cardiac output, and that means you stop your procedure as in immediately. So,
Abri,
Yo.
just talking about CO2, is that true for saline, or is it just true if you're using other forms of uterine distension? Because surely you can give 3 or 4 liters of saline in a younger woman with impunity.
no, you can't. You must be very careful. This is based on saline. So I'm not even talking mannitol and all of that, because when you open the blood vessels, your pressure inside your uterus has to be higher than the blood pressure to prevent the bleeding. So then you're infusing saline into the system, and everyone thinks because you can put up a saline drip, it's not going to have an effect. The issue is that once you start taking out bits, and the argument is going in and out to remove parts of the fibroid because you can't see anymore. Number 2, the pressure. And number 3, the volume prevents the decrease or has an impact on the patient's cardiac output. So even on saline, you must be very careful. The CO2 must not drop below 23.
Okay,
If it drops below 23, I've on some occasions, especially in private patients that that we don't want to bring them back to theatre to pay the whole hospital bill again. We will wait a while, stop all the flow of the saline, wait a while until the cardiac output improves, and then we will work again, but you must work fast and effective when you're resecting these fibroids.
Abri, just 2 questions. The first one from Premila Naidu: for a very large intracavity fibroid, would it be better to take it out laparoscopically, or would you go hysteroscopically, even though it would take a long time and risk the fluid overload? Which would you do? Where's your cutoff, basically?
No, intracavity is always hysteroscopic.
Even if it's
rather
large.
do it in 2 sessions. You'll rather do it in 2 sessions, but you always do it hysteroscopically.
Okay, good. Next question from Chupa Gwanzura: how do fibroids cause pain? It's a debate that he's having, and some people say fibroids do not cause pain.
The fibroids will cause pain for the simple reason, if you have a mass inside your muscle in your arm or in your leg. So it's actually distension of the rest of the muscle fibers, and then it's distension on those nerves.
Okay.
So that's the reason, the one reason why fibroids cause pain. And the second reason why it causes pain is if the uterus enlarges, then it pushes on different organs in the pelvis or on nerves.
Okay, thank you.
And then lastly,
Elise,
sorry, please.
just quickly, Anise Yaziki says, following on what you said about the CO2 monitoring, should we use the CO2 monitoring in place of the amount of fluid used?
Yes.
Okay, that's the answer. Sorry,
And
Steve.
just the value of that is a 23. It's 23. Upper limit of normal is 23.
Say,
Aubrey, the upper limit of normal for your CO2. I mean, laparoscopically, you sometimes get quite a high levels as well. Where would
23 is a lower limit.
Okay.
So it drops, it keeps on dropping. So I always, because I'm sitting between the patient's legs, I can see the anesthetist monitor. So I'm watching the CO2 and it'll continue to drop. It usually starts around about 36, 37, and it'll gradually drop while you're operating. And the one thing that we want to do is we don't want to put the patient in Trendelenburg. We usually use body temperature fluid, and we don't want to go in and out of the uterus the whole time to remove pieces of the fibroid, because it's that in and out that also pushes air into the uterus. So you don't want the in and out, you don't want Trendelenburg, and you don't want to have cold fluid.
All right, and then Dr. Ilana Shihama has asked how often should CO2 be monitored, but there is actually a setting on the machine that they on the where it's constantly monitored. I think, yeah, so it's continuous monitoring.
We monitor it constantly. And if you can just look at the left of my screen, you'll see that there's a triangle in the middle of the screen. So that's the focus plane that I spoke about earlier. So that's just showing where the ultrasound machine has its best focus plane, and that is running through the fibroid in this image. All right, so 3D ultrasound of a fibroid. So you can clearly see that triangular image has now been distorted, and there's a fibroid inside the cavity. That's just to see. And there you can very nicely see whether that fibroid is actually affecting the endometrial cavity. Very nice, normal triangle at the top, and then the fibroid is at the bottom. So that is a fibroid that we're going to also resect hysteroscopically. So that'll be a Figo 1 fibroid, where more than 50% of the fibroids inside the cavity. That is a very tricky fibroid. So you need to look very carefully at your myometrium and the endomyometrial junction, because you can clearly see where that fibroid is marked with a plus signs, and it actually is denting on the posterior wall of the endometrium, but it's very subtle. So look very carefully when you do your ultrasound, because you get these subtle fibroids that actually catch you out, and you can't find a reason why this patient is not conceiving or has increased bleeding, but there's a very subtle fibroid sitting in that posterior wall. This is the type of fibroid that you don't do laparoscopically. So even myself, I most probably can take out this fibroid, and it's going to take me 7 hours, and the patient is going to stand on her head for 7 hours, and it's going to be to the detriment of the patient. So this is the type of fibroid that we take out with open surgery. There's no doubt about that. Don't be a hero. Then a Mirena, very important. Some people feel that once they insert Mirenas, that they actually watch where they use an abdominal probe while they insert the Mirena, so I can see whether they've placed it correctly. And other people do a transvaginal ultrasound after they've placed the Mirena. Here you can clearly see how far that Mirena is from the fundus of the uterus. So that Mirena is completely too low. It's not going to do its job, and the patient's complaint was bleeding. And if you do the 3D ultrasound, you can clearly see where that Mirena is situated. It's not situated remotely close to the top of the cavity. And what we do look for when we do a 3D ultrasound is we actually look for the arms of the Mirena, which you can see the white lines at the top of the screen. We don't look at the shadow. The shadow gives a very nice 3D image, but that's, you'll see if you look at on your left-hand side, if you have a double screen, where your 3D marker is, it's actually below the Mirena, because the Mirena is throwing a shadow. What we actually look for is we look for we look for the arms of the Mirena to make sure that they're placed correctly. The shadow one is nice for the patient, but we want to see where the arms are. Then ovarian cysts. It's very important, in my opinion, that you should know when to operate an ovarian cyst and when not to operate them. So functional cysts should not be operated. We treat them medically, we follow them up, we give them progesterone and non-steroidal anti-inflammatories just to help break down the wall of the cyst. And we don't want to operate functional cysts because from a fertility point of view, we see the patients with a decreased ovarian reserve following surgery for functional cysts. That is a hemorrhagic cyst. It's not something that we're going to operate. It's something that we're going to treat medically. If it doesn't clear up, we can always transvaginally aspirate that cyst, but we're not going to operate that. Again, 2 cysts which are not pathological, we're going to medically treat them. There's a patient with a cyst with blood in, so you can see that cyst is busy organizing or clearing up. So on the one side, there's blood, on the other side, it's still clear. That is also a cyst that we will still treat with medical treatment prior to considering surgery. Patient with bilateral cysts, bilateral hemorrhagic cysts, medical treatment. Polysystic ovaries. It's most probably the most undiagnosed condition in gynecology in Gauteng, at least, because I cannot tell you how many patients I tell them that on ultrasound they have polycystic ovaries, which does not necessarily mean that they have polycystic ovarian syndrome, because there are criteria that they have to meet. But these are the type of ovaries that will cause irregular bleeding, and these are the type of ovaries that you must be careful if you're going to do ovulation induction. Again, these follicles look like, and the patient has 24 follicles on a, no, sorry, 25 follicles on a single scan. So these are polycystic ovaries. So we look at the size of the ovaries. We look at the inside, the typical dense area of the ovary. And then if you're not sure whether there's a lot of follicles, you can do a 3D reconstruction and very nicely see what they look like. There's a, if you have the image on its own, you can see the different size, but usually they will have these lots of small follicles. This one has 32 follicles. Another one. So what do we do with patients with polycystic ovaries, where you think the patient has polycystic ovaries? You have to do an FSH and an LH, and the most important of those is an LH, because in polycystic ovaries, the LH is typically high. A high LH will lead to a smaller chance of conceiving and a higher chance of miscarriage. So the LH needs to be less than 10. If it's more than 10 and we're going to do ovulation induction, we will put them on the pill to get the LH down. Fasting insulin, even though they may not be overweight, we need to find out if they're insulin resistant. Do a lipogram. They're associated with high cholesterol. And then the male hormones. And because these are the criteria that we use to diagnose polycystic ovarian syndrome, apart from just an ovary with lots of follicles. So what are the pathological cysts? Endometriomas, teratomas, and then cysts that we think might be malignant or suspicious. So possible malignancy, this massive ovarian cyst, it's got septae, it's got solid areas, it's got cystic areas. This is just a very ominous looking ovary. And if you're going to put color Doppler on it, then you're going to see it lights up like a Christmas tree. So this was an adenocarcinoma of the ovary. So when I saw this, the right thing to do is refer this patient to an oncologist. Do not operate them yourselves, because the best outcome is if they're operated by a gyne-oncologist. It's the same with all things. Best surgery is always first surgery, whether it's endometriosis, prolapse, oncology. These people must get to the right people first. So endometriosis. Why do we need to know whether there's endometriosis and what we can see? So we can plan our surgery, and to know whether you should attempt this or not, and whether you should or when you should these patients. And on the right-hand side is an endometrioma. And I'll show you now the way that you can differentiate between a hemorrhagic cyst and endometrioma is a typical frosted glass appearance. Hemorrhagic cysts will have white lines through them where the blood is organizing, but an endometrioma does not have those white lines. It's just this more or less solid frosted glass looking cystic masses in the ovaries. And if you put color Doppler on them, there's no color flow inside these cysts. There's a patient that we were doing an IVF with endometrioma. That's fine, we can do that. So there's an endometrioma, but she still has very nice follicles. And the current consensus at the moment is that if you do have a patient with an endometrioma and you need to operate this patient, if they're symptomatic, you do not remove the endometriotic cyst. You drain it and you cauterize the base. But by removing the ovarian, that endometriotic cyst, you damage the ovarian reserve significantly. So the international consensus at the moment is an endometrioma. If they're symptomatic, we will drain them, cauterize the base. We will take a biopsy to make sure it's not malignant, but we will not remove the cyst wall. There's another one. There are two. And then most probably the most difficult condition in gynecology for patients that want to still get pregnant and do not want hysterectomy is adenomyosis. Adenomyosis, the guidelines, I asked in one of the previous subfertility exams, the criteria of diagnosing adenomyosis. But without going into all that detail, the most important thing is to look at the size of the uterine walls on the two sides of the endometrial line. They should be the same. So 1 and 2 should be equidistant. And if they are not, it's most probably due to endometriosis or adenomyosis. And in this patient, it's easy to see because she has an endometrioma right next to that uterus that is also retroverted, retroflexed. So I have all the things that tell you that this is endometriosis: retroverted, retroflexed uterus, very thick posterior uterine wall, and an endometrioma. And if you want to, you can put your color Doppler, again, anteverted, retroflexed uterus with increased blood flow in that posterior wall, even in the anterior wall a little bit, but posterior wall a lot more. You can clearly, you can in them in the top part of the screen, and the large posterior wall with all this blood flow. This is adenomyosis of the uterus. Again, the difference in the size. So where can we see endometriosis when we do an ultrasound? We can see endometriosis in the bladder, ovary, uterosacral ligaments, rectum, and vagina. So rectal lesions, there's a rectal lesion and there's another rectal lesion. So what we're looking for in these rectal lesions is we are actually looking for this Indian head. Sorry, I was trying to get to my mouse. The Indian head fan appearance of this lesion. And you can clearly see that the architecture of this anterior rectal wall has been disturbed completely. And this measurement that I took here was to show you that you can make the wrong measurement and you need to make the right measurement if you're going to base your surgery on your ultrasound, because this lesion is far longer than what that measurement is. There you can see another lesion in the rectum. There is a lesion that has a significant diameter that obstructs the rectum. And if we do a 3D reconstruction, you can clearly see what that lesion looks like on a 3D reconstruction. And there's a short lesion. So on the 3D, you can see that there's just a very small area of the rectum is affected. But look at this massive long lesion, 6.5 centimeters with a 65% obstruction of the rectum. And on 3D, look at this long lesion. And the reason why I'm talking about the length of the lesion is because what type of surgery we're going to do. Here you can see that the lesion is actually nearly blocking the rectum completely. I'm going to try and see if I can get to my stamp marker to show you what I'm talking about. Let's see. So that's the bottom part of the lesion. And the only part of the rectum that's open is actually between those last two arrows. That's the only part of the rectum that's open. This lesion goes all the way to the top here. And it goes from there to about there. That's the lesion. It's nearly completely that rectum in that area. Oh, no, I need to just change this quickly. Right. There you can see what we find at surgery then. So that is that same lesion that we saw nearly the complete obstruction. So that is where the fibrotic tissue is inside the rectum. And the one thing that you can remember is that endometriosis in the rectum never causes rectal bleeding because it does not go through the mucosa. And because it's fibrosis, it does not cause bleeding. These patients that have bleeding are most probably secondary to hemorrhoids because of their constipation. So what do I do if I feel a rectum when I do an examination? You have laparoscopy, take good pictures and then refer. That's what I would suggest. But please don't try and operate because you're going to land in trouble. Abdominal wall, don't forget about the abdominal wall. Patients complaining about pain. So following a cesarean section, the half circle at the top of the screen. So there you can see the nodule inside the anterior abdominal wall, just beneath the rectus sheath. And that is a very painful nodule. And that's a simple open procedure that we do and go and remove that nodule. And will nearly always be following a cesarean section. Bladder, look at the wall of the bladder. We can see endometriosis inside the bladder. And that is what it looks like when we do a cystoscopy. And then kidneys, very important. I've seen 2 patients this year that have lost a kidney. One was 28 years old and one was 33 years old. And they lost their kidneys because of endometriosis. So a normal kidney, we can do an abdominal ultrasound. That's the right kidney underneath the liver. And then if you have the ureter that's being blocked at the bottom, you'll get this hydronephrosis. So in any patient that I feel a nodule, I do a transabdominal kidney ultrasound. It's easy to do. I think Pete, you and Steve also do a lot of kidney ultrasounds. So it's easy to see the kidneys. And if the kidneys look like this, it's obvious different from what the normal kidney looks like and hydronephrosis in the kidney. So if you have that, then you must know, get a urologist with you because you're going to find a nodule that's obstructing that ureter. And there's just another dilated area in the ureter, and there's no blood flow there, so that is not pathology. So what are the take-home messages? The take-home messages, in my opinion, is the following. Always do a vaginal examination when you examine your patient. Scan in the same order. Learn what is normal. Put your color Doppler on so that you can get comfortable with what looks normal. Then you'll realize what is abnormal, and you use that information to plan ahead. Thank you for your attention.
And time to run. Thanks very much, Steve. Steve, if you could unmute and thank Aubrey, I'd be very grateful, please. Steve, if you could unmute and thank Aubrey, I'd be very grateful.
Thanks so much, Abri. I mean, it's your talk's always so practical, and I personally learned a lot from you over the years on all sorts of things. So thanks so much. There were some questions, Pete, but I think we don't have enough time for that. But Abri, again, thanks so much, and covered so many important aspects, and we really do appreciate it. And thanks for your time. To actually prepare and give us this talk. So greatly appreciate it, and hopefully we can see you in Cape Town again for an in-person sort of a conference or talk as well. So hopefully that time's not too far away. Thanks so much.
Thank you, Steve. Now I'm going to ask Lorinda to show her video, please, and say a few words. Lorinda, can you unmute and say your few words, please?
Thank you for the opportunity, and Dr. Aubrey, he had to run, unfortunately, but in his absence, we just want to thank him. It was really a great privilege. He's a local and international expert, and I think all the practical tips, take-home messages, we take heed, and thank you for that. And Ashley, over to you. You can play the video, and this is just with regards to 2 products you can use after the surgery. And yes, you can watch the video and contact me should you need to order that.
Thank you once again to Laurie Murdy for our sponsorship, and we look forward to this video with great interest. Okay, ladies and gentlemen, thanks once again, Lorinda, to that very interesting animation. Thanks to Steve once again on behalf of the Pelvic Floor Foundation of South Africa. Thank you, Steve, for the use of your office and, of course, as I said before, the use of your minibar. I'm going to ask you all to have a safe journey home. I look forward to seeing you in the company next week of Professor Phil Steer, the world-famous cleverest doctor in the world. And Steve, would you like to end with your wisdom, please?
Yeah, thanks so much. I do want to thank Ashley as well for the efforts she puts into this. And of course, Pete, it would never be the same without you. So welcome back after your holiday last week. And thanks again. We're getting so many people, so much involvement on these sessions. And thanks to everyone for joining. And we look forward to seeing you next week. Thanks so much.
Safe home, Steve.
Bye.